So kia ora koutou katoa. Welcome to this session. Kevin Nation's my name. It's my pleasure, along with my colleague Dr. Ko, to moderate this session. I'm the Chief Executive of both the New Zealand and Australian Resuscitation Councils, and I'll leave it to my colleagues to introduce themselves very shortly. But this is a very exciting session on special circumstances and the specific nuances and modifications that we might make to the various recommendations for resuscitation. We've got a lot to cover in an hour and a half. Just welcome also to those people online. Just to note that there will be some pauses in the presentations for time for questions. We'll be taking questions from the floor in the first instance, and Anastasia will be our representative just moderating the questions that come through from Slido. And those people that are online, welcome. Just to note that we are limited in the number of questions that we can take. To ask a question, you click on the question mark at the bottom right-hand corner of the Slido app to type the question. We are limited to 200 interactions, so please don't use it as part of the chat function. And Anastasia will read out the questions, and if necessary, we can paraphrase those for the group. So welcome to you all. I'll hand over to Dr. Ko to introduce himself, and then our other speakers for the session.
Good afternoon, everyone. I'm Inchi Ko from Taipei, Taiwan, emergency physician, and the current EIT task force member, and happy to see you in this afternoon with the perfect weather.
So thank you, everyone. I'm Vlasis Karagiorgis from the European Resuscitation Council side, and I'm an anesthetist originally from Greece, and I was MNT coordinator for the Special Circumstances chapter with my leader, Carsten.
Yeah, hi everybody, and it's good to see all of you here. Happy that we have the option to run that session, and I assume, following Tino's words earlier on, you're all neonatologists, because you wanted to see a session where you have no clue of. Am I correct on that? No? Fine. Now, I'm more than happy that we are able to talk about special circumstances. I want to have that session as interactive as possible. This is up to you, because we know the guidelines. We want to know what you guys want to know about the guidelines. My name is Carsten Lott. My background is anesthesiology, intensive care, pre-hospital emergency medicine. This is where I've grown up. End of my days, I changed and became medical director of a big EMS in Germany, and this is where I'm just coming from. Within the ERC team, I'm responsible for all the education. I'm director training and education within the ERC board. Happy to see all of you here.
Thank you, Carsten. My name is James Tao. I'm an emergency medicine physician as well as a medical toxicologist. And I am from Dallas, Texas, at the University of Texas Southwestern Medical Center. And I was the chair for the American Heart Association guideline for special circumstances. Really excited to see everybody here and to give you the opportunity to teach you a little bit about kind of what our guidelines are, what are new, and what are important updates. Thank you.
Hi, everyone. I'm Mary McBride. I served as the vice chair for special circumstances for the AHA in North America. My day job is a pediatric cardiologist and pediatric cardiac intensivist at Lurie Children's Hospital, affiliated with Northwestern University in Chicago in the United States.
So thank you for those introductions. The way that we're going to work through this is that we've got a series of slides that talk through methodology and some summary slides of the overall special circumstances that have been looked at by both of the councils. We'll take a pause there for questions, and then we'll delve into the detail. And towards the end of the session, we'll look at some of the gaps. And will be some summary at the end, and again, time for questions as we go through.
Next slide, please. Okay, so not the writing groups. I thought the writing groups are at that stage. Okay, no, so many thanks to all the members of writing groups. Their names will show up later on. I expected them to come up now, but we will have them in a second. You can imagine it was a lot of work, and we had a lot of kind of reviewing work to do, and we invested a lot of time. That's all volunteer work. I think this is something you should keep in mind as well. So a big thank you needs to go out to everybody who supported us in production of these guidelines. And congratulations on the table for that great publication to all of you. Because I think this is, has been a lot of effort and should be honored in any way. So when we started planning for the breakout sessions, primarily we tried to find out where we got the big differences between the AHA part and the ERC part, because this is something where we can start discussing. And one of the ones we found early on is looking into the key concepts we have. So the European Resource Council, our guidelines are primarily meant for European healthcare professionals, and on our side, we are only talking about the management of adults. This is how we initially planned, but I think Mary will be more than happy to add things for pediatric cases if you have any questions on that. And one of the major differences we found out at first stage is that we as ERC cover the peri-arrest part as well. We are not only focusing on cardiac arrest, we're focusing on the peri-arrest part as well. And if you look into the definitions for that, peri-arrest in the ERC world, this refers to conditions that if you do not start treating them immediately, if you not start treating them right away, they will lead the way into cardiac arrest. This is why we feel it's important and needs to be covered. And on the other hand, and this is something we learned from the introduction session an hour ago, it is pretty important to look at survivorship, and all that post-resuscitation part. So this is something we took into account in our key concepts as well. And on the other hand, we looked for sure at cardiac arrest, because cardiac arrest, this is the cessation of cardiac output, and this is the major part we are focusing on. If you look at the writing group we have, so we had a number of experts coming out of an interprofessional and out of an interdisciplinary context. This was very important. Our Committee for Diversity and Equality was involved as well when we started composition of our writing groups. And I listed the disciplines where people are coming from. This is what you can see on that slide. But on the other hand, as mentioned earlier on, we thought it's guidelines that should help the professional, or should support the professional management at the scene or in hospital. That's very important. But on the other hand, and this is what we learn, we need to look at the survivors, and we need to look at the need of the people that are in need of resuscitation. What do they want? So it's not up to me to define that I can do nice chest compressions. So I can do that. I can teach that. We can implement that. But if in the end of the day the patient didn't want to have chest compressions at all, that makes no sense. So this is where we slightly changed our focus with our guidelines. And this is why we had cardiac arrest survivors in all of our writing groups. So they have been involved from the right beginning because we felt that was important. We wanted to know, how do they feel about it? How do they understand what we're discussing? How do they understand what we are writing? And they had a big influence in the final paper that has been published today. So I think this is a big difference. Cardiac arrest survivors supported our writing stuff a lot.
All right, next slide. All right, so for the purposes of this presentation, what we're going to do a lot of is kind of bouncing between ERC and AHA. And so one thing that you will notice that the text is color-coded in a way to help highlight some of the differences between ERC and AHA. So the texts that are in blue are going to be ERC, and texts that are red are going to be more AHA focused. So here you can see that one of the big changes we had in the special circumstance chapter for the American Heart Association was that we delineated the population in which we were referring to and sorted out the evidence and recommendations for those populations, so which includes for adults as well as pediatrics. So our our paper, our chapter does include both adults and children. Now, we do have sort of a similar concept to peri-arrest, but we called it life-threatening, and we applied it not necessarily to every single topic. So there's some topics that were cardiac arrest only, and some topics where it wasn't quite practical to say just cardiac arrest, but when we extended it to life-threatening, which was kind of just, there was an immediate risk to survival. And then similarly to the ERC in terms of the composition of the writing group, we did have diversity, equity kind of thoughts included into kind of the composition of the writing group, right? So we had writing group members who were in more junior in their career, mid-career, also late career, and a diversity of specialty, right? So we had folks in emergency medicine, pediatric emergency medicine, critical care, anesthesiology, cardiology, electrophysiology specifically, obstetrics, gynecology, maternal fetal medicine, hyperbarics, medical toxicology, pharmacy, trauma, education, and research. So a very broad group of folks, but we did not have any survivors, cardiac arrest survivors in our writing group was another substantial difference. So we'll go to the next slide.
Well, now we have the writing groups actually. So James, you may actually present the writing groups. Yeah.
So American Heart Association. So we had a number of writing group members. So just highlighted there. Dr. Ahrens was emergency medicine, med tox. Cheryl Crow was pharmacy. Dr. Easter was maternal fetal medicine. Dr. Hoffman also emergency medicine, medical toxicology. Dr. Lagana, emergency medicine, also hyperbarics. Dr. Valonis, also emergency medicine, med tox, and hyperbarics. Dr. Patel was cardiology and electrophysiology. Dr. Sutherland was cardiac anesthesiology. Dr. Tinson was pediatric critical care. Dr. Wayne, pediatric emergency medicine and med tox. Dr. Zellup was maternal fetal medicine. Amber Rodriguez was our amazing Shaw for AHA. And Ian Drennan was our senior science editor. And Dr. McBride is right here.
Next slide, please. So from the ERC side, as Carson already described, we had a full list of experts in the whole spectrum of specialist fields. I will just mention their names quickly, but not their background. So we both led the process with important input from Tino, of course, Christian Abelaris Gomez, Annette Alfonso, Just Birins, Steve Cantelo, Guillaume Debati, Sarah Nainav, Matthias Fisser, Violeta Gonzalez, Bibiana and Camilla Metzelman, Tim Meyer, Peter Pal, David Perran, Andrea Sapigliati, Anastasia Spertinu, Carl Tees, Anatoly Truller, and Charles Dickens. So, as you also see, we had the full list of experts. Next slide, please. Jumping now into methodology and the different approaches that were used by the European Resuscitation Council and American Heart Association. As you see, the European Resuscitation Council guidelines were based on 2022 till 2025 annual consensus of science with treatment recommendation publications from the part of ILCOR. However, several of the topics in this special circumstances chapter of the ERC side were not part of the ILCOR reviews. For these topics, we had recommendation based on writing groups consensus, informed by additional systematic or scoping reviews, and selected original articles. For these topics, we tried to include an evidence certainty statement where relevant. The results of all this process were delivered in the form of clinical practice guidelines ready to be clinically used and implemented immediately. All draft guidelines for all chapters in the European Resuscitation side were subject to public comment. Especially for the special circumstances chapter, we received a total of 66 comments from 54 different people, and 9 of them were included and altered recommendation after careful review and relevance to the topics we wanted to cover.
If I may shortly add to that, to the methodology part, because I feel this is a bit important. Yeah, I've been involved with guidelines writing for the third time now, and I've seen the development over time. Yeah, so when I did it for the first time in 2015, we produced guidelines. They've been highly scientific, no doubt about that. Yeah, but hard to understand. Yeah, so that means in the end you have a set of guidelines where you have a lot of place for interpretation. This is what started following the guideline process. We had nice guidelines, evidence-based, highly scientific, but then we started discussing what does that really mean and how can we implement that. Yeah? And having seen the efforts Tino put into that this year, yeah, so I think it's great because this year we tried to produce guidelines that are easy to understand, that we can bring to the practitioners in hospital and in the pre-hospital setting, to make them start working on the base of their guidelines and not starting to discuss what does that mean, how do I need to change my behavior and things like that. Yeah. So this was the background for not going that highly scientific way this time, but being a bit more practice-based in the in-hospital and pre-hospital setting.
Yeah, so thank you for that. And yeah, it was wonderful to see kind of their product, and in comparison to ours, there's definitely contrasting styles of how we present this information. So Diane Atkins earlier kind of presented on, the format by which American Heart Association presents their data, right? So we'll kind of see and how that plays into the difference in our recommendations between the two groups. In terms of the topics that we selected, so we as the writing group kind of very early on, and this process for us started in 2022. So this has been a product of love for the last 3 years, and really kind of hammered out what topics we thought were interesting and were necessary to highlight that had specific modifications to basic standard ACLS, BLS algorithms. And there was also inclusion of a couple focus updates from the American Heart Association that happened a few years earlier. So, the poisoning emergencies focus update came out in 2023, as well as the drowning focus update came out in 2024. So those were included in ours with some modifications. But beyond that, we had a high list of priority topics by which we kind of looked at, and then we're also limited by time as to how many of these topics we could then cover, and we still managed to cover quite a dramatic scope of topics. And so for each topic, we created a PICO question. We reviewed the co-stars that have been published since 2020 through the most recent set that was just published. And for each of those, we used 3 databases in terms of our literature search, which included Embase, Medline, and then Cochrane. And so 2 writing group members for each drafted those recommendations in that modular chunk format and presented recommendations by which then the group discussed it, had mutual discussion and wordsmithing, and came out with our ultimate set of recommendations. And those recommendations also included the class of recommendation and the level of evidence on that table that Diane had showed earlier. Next slide.
So you see here the full spectrum of recommendations and circumstances that were covered by the ERC Special Circumstances chapter. In this chapter, we only addressed the special circumstances for adult patients. The relevant special circumstances were addressed in the specific subchapter in the PLS manuscript for the European Resuscitation Council. As you see, we categorized these topics in 3 major pillars: special causes, special settings, and special patient groups. As James also said earlier, with blue bold font, we have circumstances that were solely addressed by the European Resuscitation Council, while standard font is used for circumstances addressed by both organizations. And similarly with red bold are the ones for the AHA. And here is also the list of the ERC Paediatric special circumstances, which are included in the relevant chapter, and we will not address them thoroughly. Next slide, please. And we will not address them thoroughly in the specific session.
Next slide. So as discussed, so this was kind of the large group of topics that we had. Specifically, some of them, were AHA had them in specific, our special circumstance chapter, where ERC did not. you can see the drowning was the focus update. We had a couple subset of recommendations, and then poisoning also subset of topics included there. There are also some overlap between different chapters, right? So, we had the pediatric, a lot of these pediatric recommendations that were included in the pediatric ERC recommendations. We also had some topics that the ERC special circumstances covered in their topic, but for HA we covered in a different chapter, right? So for obesity, that was covered in BLS rather than in special circumstances. So there may be some kind of cross-referencing that needs to be done. We're not going to highlight those specifically here in this talk.
Yeah, so we'll take a pause there just for any questions from the audience, but just while we're waiting for people to get their head around that, could I perhaps pose a question to our ERC colleagues? And in terms of the methodology, did you see the value, or how would you describe the value of having the involvement of survivors as part of the process? It seemed to be a key difference.
For me, this was a lot of added value because, in our opinion, when we started working on the guidelines for this year, we had the idea that, as I described earlier on, we kind of are looking into techniques, we are looking into scientific backgrounds, but we've completely missed the interest of the ones who are resuscitated. So we do not really have that good idea about quality of life. We do not really have a good idea about what happens to them, to their families throughout the full process. This is something we felt is lacking. And this is a perspective we wanted to add to the overall view we had at that specific circumstances we highlighted in our chapter, and this was really added value because we got input we never received from one of our medical colleagues. So these are laypersons. So we did not choose survivors with a medical background. We choose survivors from survivor organizations who had been willing to support us in the whole process. And they've been able to provide input from a lay perspective, but also from a perspective of somebody who survived. And we had the added value as well. We had a couple. So we had the husband that had been resuscitated, and we had his wife who kind of went through that whole process. And they really have been able to give us very valuable insight on what's happening in the family during that peri-arrest situation. What are their feelings? What are the outcomes? So what do we need to really take care for?
Thank you for sharing. And because I think there's no online question, before we dive into the top 5 special circumstances, I would like to ask maybe what were some of the most challenging topics in your chapter?
A lot of them. Yeah. So one thing that, when you look at our chapter, especially for the HA chapter, you'll see that the level of evidence is very low throughout, right? Like these are special circumstances, namely because they're rare, and it is hard to study rare diseases, right? So it's hard to get a randomized controlled trial, especially poisoning, and it's also not ethical to poison people to get randomized controlled trials. So, we're living on kind of a spectrum of, descriptive studies, right? Case reports, case series, so some observational studies. So it's just very limited evidence. And also kind of thinking through the topics as to what we really want to prioritize and include. And some things we thought about, right? Like there may not be a ton of changes, like benzodiazepines, for example, but then it may not be great to be silent on it. And but I think overall we came out with a great set of topics to cover with meaningful differences between standard resuscitation.
I think also the inclusion of the either peri-arrest state or the life-threatening state. I think there were many times in our conversations where we paused to ask ourselves, is this just really good critical care? Is this just really good emergency medicine? Or is this a true deviation, if you will, from from standard life support, standard resuscitation. And so that's a fuzzy line. It's gray at best, right? And so where do you draw that line? And I think we bounced that idea around many times.
Like maybe we're going to go further with like topics included in the ERC and AHA, and like we are now introducing the significant changes in the guidelines.
So, significant changes compared to the 2021 guidelines published by the European Resuscitation Council. As you see, the first topic that there was a significant change is anaphylaxis. Even from 2021, the recommendation for corticosteroids was downgraded, but now ERC recommends against the routine use of corticosteroids in an anaphylaxis setting. Moving to hyperkalemia, we have revised the hyperkalemia algorithm based on the new uncertainty on evidence and the use of IV calcium, which we maintained the specific recommendation, and we'll discuss thoroughly on that later on. With a stronger focus, though, on an early implementation of potassium-lowering strategies. Moving to coronary thrombosis, a clear change, which is quite important in our guidelines, is that there is no more recommendation for routine coronary angiography in stable patients without ST elevation or equivalent on ECG immediately post-ROSCO. Moving now to traumatic cardiac arrest, there is also a set of interesting changes, and then Carsten will give us some interesting insights on that as well. As invasive procedures are now prioritized according to clinical priority rather than the way they appear on the algorithm. And we try to make it as clear as possible in the current version of the guidelines, while the use of RIBOA is de-emphasized and recommendation is maintained only at the level of clinical trials. Moving now to droning, in alignment with the rest of ERC guidelines, call for help is moving a step earlier. So if you see an unconscious victim, then call for help is the next step to do, simultaneous with the emphasis on the ventilation first approach compared to the standard BLS algorithm. Moving to the second set of significant changes in our guidelines. In cardiac arrest in the operating room, a systolic pressure than the 50 millimeters of mercury is considered also almost equivalent of cardiac arrest, and chest compression should be triggered. Resuscitation in these patients, especially in the pre-arrest phase, starts with lower initial adrenal doses of 50 to 100 micrograms, and then adjusted incremental dosing. If these initial doses are ineffective, then we move to the full standard dose of 1 milligram. Of course, we have suggestions for early SMPR implementation in settings it is already implemented. Left ventricular assist devices, we are quite proud for this topic, as they were addressed for the first time in the ERC guidelines. Now moving to cardiac arrest in sports, there is a more detailed presentation of the content focusing on the use of sports in relevant big events as a motor to raise public awareness, but also to raise awareness about the risk that exists for non-elite athletes that are occupied at a recreational level. Finalizing this session, this set of significant changes, with resuscitation during pregnancy. Additionally to the 4 H's and 4 T's, which you already all know, we have added the 4 P's, which are specific reversible circumstances for the pregnant patient. Manual uterine displacement is preferred over lateral tilt, and there is the emphasis of the 5-minute strict rule of resuscitative hysterotomy or resuscitative delivery, and there is a shift to immediate initiation of the process and activation of the mechanism to achieve hysterectomy the soonest possible. As it seems, hysterotomy is not futile even beyond 5 minutes. And we also recommend specifically for these patients that IV or IO access, similarly to the HA colleagues, is most effective when it's done above the diaphragm to avoid aortocaval compression problems. We addressed some other also new topics in the 2025 guidelines. We'll just rush through them. Even though toxic agents were thoroughly analyzed in the 2021 guideline, this time we focused on toxins producing hypothermia and how to manage this condition. Left ventricular assist devices, we already talked on them, as well as the new focus on sports. We had also included microgravity resuscitation as space exploration goes beyond and commercial traveling to space becomes more accessible for the rich one, at least. It's something that we may have to deal with in the future more and more frequently. We also included a comprehensive algorithm on management of dialysis patients and trying to also to cover people with skeletal abnormalities. We only find sufficient evidence for pectus excavatum. That is why we also included this topic in our recommendations.
Thank you. Next slide. Significant changes that are worth commenting on from the American Heart Association. We'll start with a specific focus on extracorporeal life support. As many of you are already aware, there is growing literature on the use of mechanical support in general and extracorporeal support in the form of ECMO for adults and children, both in a cardiac arrest or peri-arrest state with potentially reversible etiology, such that there is an off-ramp, if you will, to that mechanical device. And some specific settings that we noted were that in anaphylaxis, asthma, after cardiac surgery, during or after a cardiac interventional laboratory procedure, in the setting of hypothermia, pulmonary embolism, and multiple poisonings. As anticipated and noted this morning, hyperkalemia is expected to be a dicey topic for all of us, and that we did change that recommendation. In similar fashion, we highlighted the uncertainty and the strength of previous evidence supporting the use of IV calcium and IV sodium bicarbonate, and encouraging a critical appraisal of that risk of harm, as we know that CPR is a well-established and positive move if that is interrupted. Additionally, COVID did bring a couple positive things, and one was a focus on cardiac arrest and instability in the setting of high-consequence respiratory pathogens, so things like COVID-19 and other respiratory pathogens, that we learned that chest compressions, bag mask ventilation, defibrillation, suctioning, and endotracheal intubation, all of those should be considered aerosol-generating procedures, which do pose a risk to those around them, including the resuscitation team members. And we also learned the value of PPE. Overall, the rates of severe acute respiratory syndrome, such as SARS-CoV-2 transmission to the team members, was significantly decreased in the presence of personal protective equipment. Opioid overdose as a growing epidemic. Having an opioid antagonist such as naloxone given to people with respiratory arrest who have a known or suspected opioid overdose. To increase the education to train rescuers, lay rescuers, and members of the general public, all then being trained to administer naloxone. And that furthermore, opioid antagonists should be provided at discharge for those who have survived an overdose. Other topics that are worth mentioning very quickly are a focus on alternative CPR techniques, such as interposed abdominal compressions. As mentioned already, cardiac arrest in the cath lab or cardiac intervention suite, electrocution, gas embolism, hyperthermia, LVAD, as we have mentioned, and then many poisonings, and specifically that of volatile hydrocarbons.
So we have a short pause here. Is there any questions? And I'll check if there's one online. So if there's no, I have one question for you. Yeah, I have many. Yeah. So like before we dive into the top 5, like where are your common grounds for recommendation in special circumstances?
It seemed to me that hyperkalemia was very similar, with similar reasoning behind it, that we've learned that our dogma in common practice didn't really map out in the same way from a scientific perspective, and that we're downplaying that focus on calcium and bicarbonate and continuing our strong focus on high-quality CPR. You agree?
Yes, so I personally felt that our common ground start much earlier because if you look at special circumstances and at the definition of special circumstances, and this is where we both started this, we have standard algorithms. We have them for basic life support, we have them for advanced life support, we have them for pediatrics, but we cannot really apply these in special circumstances. This is where we all started. So we know this is our mantra, do not interrupt chest compressions. This is our mantra for years. And increasingly we understand that we need oxygen. So these are the two absolutely strong points in resuscitation. Do not interrupt chest compressions and give oxygen. That's what we need. But when we start thinking about special circumstances, we need to leave that behind. We need to throw that mantras away. We need to walk another way. And this is the common ground I felt when we started our first discussions. And even if you look into the differences we have, these are not really different. These are slightly different interpretations, but nevertheless walking down the same route, treating special circumstances with a specific approach.
Okay, thank you for sharing. And now we are going to our top 5 treatment recommendations from the ERC and AHA.
Yes, I'm happy to start with the hyperkalemia discussion, but nevertheless, I forgot one special circumstance I need to add today, and this is German rail, cardiac arrest in German rail. Taking German rail to come to a conference is horrible. So I managed to get in here 20 minutes before that session started. No, so first differences we want to discuss is hyperkalemia. Bearing in mind the process, how we structured the hyperkalemia recommendations within the ERC setting, I'm happy that the whole writing group survived. So we had that many discussions on that topic. And it was really pretty hard discussions, and these discussions kind of reflected that big gap between the scientific evidence we have on the topic, and on the other hand, our practical knowledge we have on the topic. So I think, and this was for ERC, one of the most important reasons for giving our recommendation, all of you who have ever seen a serious hyperkalemia with significant ECG changes have noticed that this reacts on calcium. It does. Even if we cannot prove that with the studies that are out there, with the publications we have out there. So our clinical heart, when working in ICU, does not allow or did not allow to say no in that circumstance. I do not give calcium because I've seen it working that many times. I do not want to get rid of that. So this was kind of the expert consensus outweighing the significant results we had from the publications. But these are mainly describing patients in cardiac arrest without hyperkalemic patients. This is something you need to keep in mind as well. So the recommendation coming out of ILCOR is based on a publication that focuses on cardiac arrest patients but does not really include hyperkalemic cardiac arrests. So this is something that did not really match our recommendations we want to have. So the big difference from the ERC perspective is we are providing recommendations for the peri-arrest and for the cardiac arrest period due to suspected hyperkalemia. We even go to an oral intake of calcium, of potassium absorbers to lower the levels of potassium in the body to be preventive at that stage. We decided to continue our recommendation on the use of IV calcium. We recommend against the routine use of sodium bicarbonate in the peri-arrest patient. We're not that sure about the arrested patient, so this is where we still did not really exclude it. Let's put it that way. Then we have a somewhat more conservative approach to use of glucose in the patient. So we're starting with 25 grams combined with 10 units of insulin to lower or to switch to ship the potassium into the cells. And we keep on recommending, for the same reason, the nebulized beta-2 agonist as an adjunct to that. And in our setting, we felt it's important to have dialysis in mind because, in our opinion, this is once again a very clinical point, but it's a pretty effective intervention to get rid of that potassium in the body.
Yeah, thank you. So from the AHA standpoint, we also had our similar struggles, right, in terms of how we interpreted this data. So I think coming from a different mindset of that this is purely cardiac arrest recommendations really changed how kind of our recommendations kind of came out, right? Like we also have the same anecdotal experience of giving somebody who had known hyperkalemia some calcium, and you see the EKG change in front of you, right? Like we've had that experience. Now, where the cardiac arrest topic comes into, makes it interesting, is how do you know if somebody comes in with a cardiac arrest is due to hyperkalemia, right? And that question is very difficult to answer because, you know, somebody who's in cardiac arrest and acidemic, you're going to measure their calcium or potassium and it's going to be high, right? So is it, you know, did the hyperkalemia lead to the arrest, or is the hyperkalemia a reflection of the cardiac arrest? And we don't know. We also do know that there was a COCA trial that had, you know, all comers cardiac arrest. They excluded hyperkalemia in that subset. In that population, calcium did not benefit and potentially even caused harm, right? So, you know, and then they actually did a subgroup analysis of suspected hyperkalemia based on EKG changes, and you could tell that when you kind of looked at their supplement, that a lot of the patients that were included didn't truly necessarily have hyperkalemia, right? And in that one, so that became the big question, right? Do you know if they have hyperkalemia or not? If they don't, you give calcium, you potentially cause harm. If you do give it, if they do have hyperkalemia, it may be benefit. So that's why kind of the language in the recommendation came out as it was, that just really uncertain evidence in humans, right? And there's animal study data that shows that in pig models that there may not be a benefit with calcium either. So, so it just became a very difficult question. The sodium bicarbonate, kind of similar, very lacking of human data. There is some animal data to support its use, but again, just uncertain is kind of where we left it. Insulin glucose, while it does drop the glucose, or drop the potassium, we do know that that happens, but again, in a cardiac arrest state, becomes a little bit more uncertain. And then beta agonists, we also thought about this one, right? You know, it is effective in this peri-arrest period. However, a lot of these patients in cardiac arrest will be given epinephrine, right? What is the added benefit of adding a nebulized beta agonist in the setting that they've already received epinephrine? Like we really didn't think that there necessarily was much beyond there. And then dialysis was also an interesting question, right? Because there are case reports, and you can see, you know, the ERC paper does, you know, state good evidence supporting dialysis use, you know, even in cardiac arrest, but like logistically, how do you get somebody who's arresting on dialysis, right? Especially in the setting where they may or may not even be arresting from a hyperkalemic cause. So that's where we kind of didn't give a recommendation on dialysis. We did discuss it quite a bit. So this was an interesting topic.
Next slide would be the algorithm. Do you want to rephrase?
Okay. So next page, so as you can hear, we are in the end on the same page. So this is not really different. It's slightly different interpretation of the existing data sets. And this is what led to our differing recommendations. So right-hand side of that slide, I can show you the standard kind of changes in ECGs and the result if providing IV calcium. But I think everybody here in that room or out there on the screens working at ICU has seen that effect. But this is only a small period in time where you can get the patient at that stage. And then this is clinical experience, yeah, then it's proven to be effective, yeah, because you can really can reverse that ECG changes. Yeah. As James stated in the right way, our algorithm does mainly focus on the peri-arrest patient. So it's mainly meant to get you an advice how to get rid of the potassium. How to be able to get the patient into a more stable situation before getting him in cardiac arrest. And this is how we kind of recommend that kind of procedures here, because in the cardiac arrest patients, you will not have ECG changes and things like that. So what we do is we kind of look at the concentration of potassium, of the blood concentration of potassium, and this is where we kind of recommend different management strategies, and this is what in the end is displayed in our algorithm, and it includes calcium, insulin, glucose, and the potassium binders, as well as the nebulized salbutamol. But this is where I'm on the same page with James. If the patient is arrested, I wouldn't start them on nebulized salbutamol. It makes no sense.
So the next slide, this is the AHA recommendation table, largely kind of what I had highlighted earlier. You can note that, very soft recommendations. These are 2B recommendations and a 3 no benefit recommendation for beta-2 agonists in the setting of cardiac arrest. And you can see the level of evidence, right? It's, limited data at best and mostly expert opinion of our writing group.
I think that is best summary in that case. So it's expert recommendations will be made for AHA and for ERC.
Yes, I feel the struggle on writing the recommendation on this topic. And now we're going to the second one, the left ventricular assist device, the LVAD. And this is for the first time included by the both guidelines.
Yeah, well, we're quite happy from the European Resuscitation Council that we actually took on to include this specific topic. And we will start discussing the similarities between the approach of the two organizations, because for the specific circumstance, we both created an algorithm to manage these patients. So you see the entry of the algorithm is the unresponsive adult patient with a durable LVAD with absent or abnormal breathing for the ESC side. While it looks similar, this second part of this sentence is actually a slight difference, because it actually defines the cardiac arrest for LVAD patients as lack of pulsatility for the majority of the devices makes difficult to recognize with standard measures lack of circulation. So while the entry is similar, there is still a difference. The next step is to call the LVAD team. We're mainly talking for institutions where an LVAD team is on site, and that can be called to be involved immediately. Most of these patients will be treated in specialist sites, and when even a simple problem of other medical nature appears, they will also be admitted to a specialist hospital for the majority of cases, at least in most places throughout Europe. Next step is after initiation of the first measures and chest compressions and ventilation as well, is to assess for impaired perfusion. Due to the fact our entry focuses on the arrested patient, assessment for perfusion in the ERC side is at a lower level. We both have different management pathways depending on the number of rescuers, and troubleshooting the devices according to the signs on the LVAD screen is a priority.
Yes, just to re-comment on those similarities. Our recommendation also includes unresponsive adults as well as children with a durable LVAD. Unlike the European healthcare system, if I may, the healthcare system in the United States anyway, not necessarily Canada, but will lend itself such that there may be patients with durable LVADs who are quite distant from a VAD center. So there may be a different additional step to be in communication with an expert who knows how to manage a VAD. Given that the VAD delivers cardiac output, the assessment focuses solely on impaired perfusion and thereby impaired cardiac output. Of course, that can, also turn into a respiratory event, but that's where the focus is. And then, of course, we have our algorithms in the coming slides.
Next slide, please. Coming now to differences, as you see in the ERC algorithm, we suggest initiation of the resuscitation process in patients who are unconscious and not breathing normally. So these two signs, as I said before, are equivalent to cardiac arrest. When we have a team of multiple rescuers, then CPR and managing of the device, troubleshooting, happens simultaneously. However, when a sole rescuer is present, then initiation of chest compression can delay up to 2 minutes maximum in order to address initially problems related with the device. We also included post-cardiac surgery and extracorporeal life support recommendations, and we have an extensive stepwise approach to troubleshoot the LVAD patients and the device itself.
Great. Again, the resuscitation begins with the assessment of perfusion of the presenting patient. And if there is only one individual single rescuer present, CPR is to be started immediately. And then in reference to our post-cardiac surgery recommendations, if someone is inpatient, which isn't what this is focused on, there would be movement towards immediate resternotomy if they're in that first kind of 1 week to 2 week time frame before there's significant scar tissue in the chest. And if you're beyond that time frame and you're outpatient, then the risk of dislodgement, we believe, although the literature is sparse and also they argue against each other, that it's safer to start CPR and give that person cardiac output and take the risk of potential injury or dislodgement to the VAD.
Well, next slide, please. Adding to what Mary just said, in the ERC algorithm, as we said, we start with abnormal breathing or lack of breathing and impaired consciousness. So CPR should start in a simultaneous assessment of the device function. However, when we have a single rescuer, then you can see on the right side of the algorithm that we have specific interventions based on what is shown on the screen. So the screen may not responding at all, so it may be a problem of power, or we should connect the patient to power outlet or change batteries. Or we may see a controller that is damaged, broken, we should exchange the controller. Or we may have a specific indication for high power that could indicate high pressure thrombus, or even a suction event in the case of LVAD patients. So while CPR is performed, if we have a multiple team managing this patient, then somebody else takes care of the LVAD. Simultaneously, we address other reversible causes that are quite relevant for this patient, like ventilation problems. So we should provide ventilation and oxygenation as soon as possible, and if the effort is prolonged, then we should also consider invasive measures. Then you see ECG is the next step. And when we were preparing all this algorithm, I tried to find the evidence for the ECG that is slightly delayed, we can say, in the algorithm. The reason is that patients with LVADs may have sufficient perfusion even with malignant arrhythmias. So most of them will also have an implanted defibrillator as well, but it explains somehow why we address the ECG disturbances at that level below. Simultaneously, we should call for expert help, and especially an echo expert with either transthoracic or transesophageal for higher quality images expertise to identify potential causes that led the patient in this condition. If after this initial management the patient is still in circulatory failure, which is defined slightly differently compared to the standard patient, as we said, we do not have pulsatile flow and IBP failed to measure correctly, so we need advanced measures to measure pressure accurately, either an invasive arterial line or a Doppler device. If the patient is still in this case in circulatory failure, then we should proceed depending on both the findings of the echo but also the days post-implantation into either ALS and extracorporeal life support if we are many days after the implantation, or if we are in the first 2 weeks, as Mary also said, to proceed with the resternotomy. If the patient is not in circulatory failure no more, then standard ABCD approach with special focus on D and stroke as a reversible cause should be considered.
Absolutely. Again, perfusion is the first fork in the road there on our algorithm. Patient presents, and do you have adequate perfusion or not? And so if you do, then hold off on CPR and monitor your perfusion, get in touch with your VAD center, and start to think about non-cardiac, non-VAD causes of decompensation. If you do not have good perfusion, then begin chest compressions. As stated already, the potential benefit of CPR outweighs the theoretical risk of device dislodgement. And then hopefully you are not alone with this patient and you have a friend who can start to troubleshoot the VAD, such as listening for the VAD hum, looking at the drive line and the power source, et cetera. And calling for help as needed with either a VAD center if you're not at one, or even the VAD companies are very helpful in helping troubleshoot. And then in addition to that, as stated, there is also in that gray box along the side, I suspect you cannot see that from here, are also some pointers for looking at perfusion. They're not new things. They're all usual clinical suspects of how one assesses perfusion, and secondary etiologies of unresponsiveness, such as stroke, as mentioned.
Okay, so we're going to our third topics, the pregnancy, always included in our special circumstances. I think the idea is the same, but some of the phrasing is a little bit different.
Well, we totally agree with this statement, actually. In the European Resuscitation side, European Resuscitation Council side, we again initiate the process with the unresponsive pregnant adult patient with absent or abnormal breathing as a criterion for cardiac arrest. Left lateral uterine displacement is suggested by both organizations, and there is just a difference in terminology when it comes to resuscitative hysterectomy. However, we focus on delivery within 5 minutes, also mentioning the absence of futility if this process goes beyond this time point. ECPR in pregnant and peripartum patients may also be implemented, as we say, based on multidisciplinary decisions. We already discussed about the preferable access of IV or IO above the diaphragm. There is a common grounds in recommending for removal of fetal monitors during defibrillation to avoid burns, as well as infusion of IV calcium as an antagonist for magnesium intoxication.
Exactly. I don't feel the need to repeat you.
Well, similarities are actually covered already, but let's proceed with the differences then. As we already said, in this chapter we included for the first time the additional 4 Ps, which we will show in detail in the next slide. And we discussed thoroughly about hypovolemia as one of the top reversible causes from the 4 H's and 4 T's.
Once again, our focus is that on cardiac arrest specifically here. We also have a section on the management of life-threatening amniotic fluid emboli, since that is specific to this. We also have the inclusion of some systems of care and teamwork education, having a massive transfusion protocol, having a team that is prepared via practice before this event happens, if you have that luxury. And then additionally, our MFM colleagues taught us all about avoiding atropine, ondansetron, and ketorolac in combination as a therapy. And I also, before we leave differences, just wanted to add, I personally love the infographics and the graphics in general used in the ERC diagrams, and the 4 Ps is a nice mnemonic. These are good education tools.
So thanks for that, and let's dive into more details of the cardiac arrest in pregnancy European Resuscitation Guidelines. So as you see in the first recommendation, we have left lateral uterine displacement, which seems to be superior compared to lateral tilt. And you see we have 2 suggested maneuvers that could be implemented based on the position of the rescuer. Also, when it comes to resuscitative hysterotomy, as we said, the focus is early preparation and activation of the mechanism and the team by the moment a pregnant woman is in cardiac arrest. It's a time-sensitive intervention and should happen as soon as possible. However, it's one of the major messages and major changes. This process is not futile beyond 5 minutes post-arrest because benefit still pertains for the arrested woman and the baby itself in certain cases based on the weeks before birth. Moving now to extracorporeal life support and ECPR. Early implementation is based, as we said, in multidisciplinary team decision because it's not always easy to be implemented. So we need a setting there is a relevant expertise for such a process, such an intervention to be initiated. And it can even be initiated before the cardiac arrest itself. If we think a woman that is deteriorating and we have an impending circulatory collapse, it is much better to initiate the process at an early stage because prevention is always better than cure. Moving now to the reversible causes. We've said already that we have the 4 H's and 4 T's. Hypovolemia is one of the dominant ones for the pregnant woman. It doesn't mean that the others do not exist in slightly different formats. But let's focus on the new 4 P's. We have preeclampsia and eclampsia as a reason to lead pregnant women to cardiac arrest. Puerperal sepsis, placental and uterine complication, and there's a whole spectrum of them. And peripartum cardiomyopathy, which is quite common in incidence at last, especially in registries of specialist centers.
At the AHA, we also have our algorithm for cardiac arrest and pregnancy. Of course, first and foremost is high-quality CPR. And then, in addition, manual left lateral uterine displacement in order to try to improve blood return to the maternal heart. And while that's all happening, hopefully, again, you have friends at the resuscitation with you, and a team is preparing for resuscitative delivery with the goal of having the baby delivered by the 5-minute mark of the resuscitation. The potential, we recommend for the potential for ECPR, given centers that have the resources to accomplish that goal in pregnant and peripartum patients who are not responsive to standard resuscitation, and a massive transfusion protocol that offers a balanced transfusion strategy, and also keeping that thought in the front of your brain about the suspicion for life-threatening amniotic fluid bolus.
Sorry, I want to just highlight one additional thing for this algorithm. I think that's really important that we kind of changed was that really we did slightly change the terminology here, focus on maternal arrest versus neonatal resuscitation, right? So, this process is, really focused on the mother and, resuscitating the mother, and secondarily, if it also helps the baby, great. Right? So that's why, when you're looking at this algorithm, there's 2 separate pathways. So it's not truly a fork of if this or that, right? This is a concurrent management of having one set focus on mom and one set of specialists that's focusing on starting the resuscitative delivery piece, right? So that's kind of one of the big changes to this algorithm.
Yes, and I always wish there's some friends to resuscitate with me. And now we're going to the 4th topic, that is hyperthermia. That is really fantastic algorithm.
Yeah, it's fantastic and it's complex. Yeah, let's call it that way. But yeah, this is my good friend Peter Paul, who has been involved with that, and we know from former years, where he's been pretty active in hypothermia and has started working on the peri-arrest situations and hyperthermia, that he's really pedantic on that. Yeah. You will have an excellent talk throughout the conference on that topic by Peter himself, so I can only present what I understood from what he integrated in that chapter. Yeah. I think the most important bit in the ERC algorithm on hyperthermia is that we do not only cover temperature, we cover dehydration, and we cover electrolyte disturbances as well. So this is a kind of a global view on the whole problem of hyperthermia and the eventually resulting cardiac arrest. So bad news, and I think this is what AHA experienced as well when starting looking into the topic. There is no data available. There's not really data available where you can base a scientific recommendation on. So all we can do in hyperthermia is we can kind of collect the expert consensus and can take decisions out of that expert rounds, and this is how we built up that algorithm. I think the most important bit in the peri-arrest situation and even in cardiac arrest is to cool the patient down as soon as possible. If you really have that hyperthermic problem, you should cool them down. And what is proven, and I think this is what AJ is going to state later on as well, is the immersion is the most effective method you can use to cool your patients. So what you need a bath tube, you need a lot of ice, you need a lot of cold water, and then you need to put your patient in to get them cooled down as soon as possible. Once you're getting control of the temperature, so temperature is not going to further raise, you're even able to lower the temperature in your patient, then you can start looking at the additional problems these patients always have. And this is a natriemic problem, so they are hyponatremic, and this is something you need to cover. And on the other hand, they are dehydrated. They lose a lot of fluids, a lot of water during that hyperthermic period, and this is what you need to take into account as well. And that's what we cover within our algorithm as well. So we try to cool them down as soon as possible. On the other hand, while lowering the temperature, we look at the electrolytes, and further on, we look at the hydration status and try to compensate that as soon as possible.
All right, next slide. Okay, from AHA side, so this gets a little complicated. So one, we did focus on cardiac, we focused on life-threatening in this one as opposed to the AHA focus on cardiac arrest in the previous one. The other complication here is that this got split up into a number of different recommendation tables. So we had adult life-threatening hyperthermia, we also had pediatric life-threatening hyperthermia, and then we also had 2 different toxins that had recommendations on hyperthermia. And that was each split into 2 tables. So like these recommendations are on like 6 recommendation tables. So that's why it's really complicated and spread out. So yeah, I think for the most part, our recommendations are gonna be in line with ERC. We didn't focus quite as much on the less severe degrees of hyperthermia. Really, we started from severe hyperthermia that is immediately life-threatening. That's kind of where we took off. In terms of kind of cooling rate, we certainly agree. I think the rate of cooling out there at the 0.15 degrees Celsius per minute is pretty well adopted. It's also adopted at the Society of Critical Care Medicine guidelines that was also recently released. And we also agree with ice water immersion. Now, what we did stay silent on, and the group did discuss this when we were kind of putting this together, was how do you put somebody in, ice water, right? And that logistical piece is going to be challenging and probably institutionally dependent. There's definitely talk about body bags. That may be beyond the scope of this talk, but that was, something that was discussed. And then I think there was also one other difference that between ERC and AHA was the interpretation of the literature around dantrolene for hyperthermia. So for us, this was at the bottom. It was a B. There's 3 no benefit for dantrolene. Now, when we looked at the evidence for all hyperthermia, and we called it environmental hyperthermia here, there is no benefit. Now, there are specific case series of dantrolene being used for toxins like MDMA that is out there. The data is a little bit conflicting. So ultimately, from our side, we really did not have a great recommendation, strong recommendation at all for the use of dantrolene here.
Yeah, just to comment on that, we had a lot of anesthesiologists in this writing group, and Peter is an anesthesiologist as well. And we kind of have some experience on the use of dantrolene in malignant hyperthermic patients. And this is why we always tend to early on use dantrolene in patients that have some kind of hyperthermia that we cannot really cover with other measures. And this is kind of the expert experience that led us to come to that recommendation.
So now we are going to our last top 5 topic, that is cardiac arrest caused by opioid poisoning.
So, well, it's a quick one. The European Resuscitation Council suggests that the existing evidence all around is not sufficient to recommend administration of an opioid antagonist like naloxone in cardiac arrest that is caused by opioid poisoning. And there is also an ILCOR review on that, and we found that the evidence included there for cardiac arrest specifically do not suggest the implementation of such a measure. However, things are different for peri-arrest patients that are almost developing respiratory arrest, and they are just before cardiac arrest. But for this special circumstance, subspecial circumstance, we may say, we did not include the recommendation in our guidelines.
Okay, so from the AHA side, we landed on it may be reasonable to use an opiate antagonist for cardiac arrest. So due to opioid poisoning. And the data here is evolving pretty rapidly, and probably for the next guideline cycle, it may look different. So there were some North American studies out there looking at this topic of, it was actually looking at non-specific cardiac arrest and the use of naloxone in the resuscitation of those patients. Now that recommendation is not ready for prime time. That was retrospective data that looked at it. There are some animal studies that suggest maybe there's a mechanism by which opioid antagonists can improve cardiac arrest outcomes. So the thing about those retrospective studies that came out in the US was that it was in patient populations that were high prevalence of opiate use disorder, right? So, thinking about that and thinking about the retrospective nature of that study, there may be a signal there that suggests that opiate antagonists may be beneficial in this setting. So that's kind of how we landed on it. The other kind of the side of the coin is that using opiate antagonists, as long as it doesn't interfere or slow down other important ALS, BLS steps, has very little harm, right? So you have a slight benefit possible, but effectively no harm. In that situation, then that's how we landed on may be reasonable.
I think what you need to keep in mind concerning that topic is that we do not really imitate Americans in everything. So thanks God we do not really have that big opioid problem in most of Europe that is kind of coming out of the United States. So we didn't have to think that much about it.
Yeah, that's a great point.
Yeah, thank you very much for those insights.
Sorry, one more. So
Sorry.
This was a different topic, slightly different topic that was only here, the recommendation table in the AHA.
Yeah.
So one thing that we really wanted to put into this guideline was the concept of take-home opioid antagonists. We call it more commonly take-home naloxone, right? And the idea here is that those who survive opiate overdoses have a very high mortality subsequent to that, right? In the first 72 hours, in the first year after they have been resuscitated in an overdose. And so it is very important from a secondary prevention side to give them naloxone, and not just a prescription, right? Because a lot of people will not get the prescription filled, but rather to hand them naloxone and provide teaching on the use of naloxone in case of an overdose, right? And so it may not just only help them, it may help people around them, right? So getting naloxone out in the community is very important. So that's why we landed on this set of recommendations as well.
Thank you. We're mindful of time, and we do want to move on to the research gaps. It's one of the things that ILCOR has been discussing at length over the last few days are the gaps in the research. So if we can move on to that, we'll leave questions to the end.
That sounds great. I made an executive decision. I'm just going to say these because they're all combined into all combined. So these are the gaps that have been identified by both groups looking at the same science. Look at us being a team. So in the context of anaphylaxis, does a higher dose of epinephrine, such as 5 milligrams administered intramuscularly in adults, confer benefit in cardiac arrest from anaphylaxis? What is the role of intranasal adrenaline in the pre-arrest phase? What is the optimal positioning of peri-arrest patients? In cardiac surgery in the cath lab, is there a benefit to 3 stacked shocks in VF in adults after cardiac surgery compared with standard measures for ALS in the context of VF? And high consequence respiratory pathogens, how can teams mitigate the effects of PPE on resuscitation team performance and healthcare professional fatigue? In hyperthermia, which are feasible and effective cooling techniques in cardiac arrest? In hypothermia, is there a common temperature threshold for defibrillation? Which is the optimal regime for adrenaline? In traumatic cardiac arrest, when is the optimal time to start chest compressions? Is there a benefit of resuscitative thoracotomy? In cardiac arrest in sports, what is the etiology of currently unexplained sudden cardiac arrest? Hyperkalemia, what is the clinical evidence supporting IV calcium or IV sodium bicarbonate administration? It's limited in humans and uncertain to improve survival or favorable neurologic outcomes. What is the utility of other therapies intended to lower potassium concentrations in the setting of cardiac arrest? It's unclear when weighing their possible benefits against the risk of harm if well-established interventions such as CPR are interrupted. For local anesthetic toxicity, is there a benefit in lipid emulsion administration? In cocaine poisoning, in adults with cocaine-induced coronary vasospasm or hypertensive emergencies, administration of beta-adrenergic antagonists is not recommended. In LVADs, what is the best method to confirm cardiac arrest in either an adult or a child with an LVAD? In pregnancy, what is the optimal airway management device and timing in cardiac arrest in pregnancy? Which is the timing threshold to initiate ECLS in pregnant patients? For pulmonary embolism, what is the optimal amount of time chest compression should be continued after patients in cardiac arrest from a PE who've received systemic fibrinolytics? What is the most appropriate fibrinolytic drug scheme? For beta blocker, calcium channel blocker poisoning, does high-dose insulin therapy for adults and children with life-threatening beta blocker or calcium channel blocker poisoning, administered in addition to or instead of standard vasopressors, reduce mortality or ischemic complications? For the opioid overdose, what is the benefit of naloxone when given to adults and children in cardiac arrest with suspected opioid overdose? And in asthma, is there any benefit from manual decompression in cardiac arrest? We'll be standing by for all of you to answer those questions. But food for thought.
Yeah, that's a bunch of questions. So, we're in the last 12 minutes of our session, and we're back to our top 10 key message from each of the guidelines.
Okay, I need to get up for that. Yes, this is nothing I can tell you sitting. Yes, which is the slide where the camera is focused on? Is it this one or is it this one? Because I would like to highlight some points on the slide. Otherwise, all there out on the screen will not see what I'm doing. they can see both slides. Okay, so let's start with that slide. So I'm going to go slightly down. As I indicated earlier on, yeah, so the most important bits in cardiac arrest, yeah, are, oops, oh yeah, can I use that somehow? Hey, that's good. Yeah. So these are the most important bits. Yeah. So we have minimal no flow time in cardiac arrest. Yeah. This is what we want to have. And on the other hand, this is what we learned in the past years. We need to clearly focus on oxygenation. That's what we need to do. Yeah. Nevertheless, and this is what I told you earlier on, when we talk about special circumstances, yeah, we need to throw that mantras overboard. Yeah. You need to keep them in your mind, yeah, so don't totally abandon them, yeah, but nevertheless, you need to critically review them. And you need to look at your resources in special circumstances. This is what we discussed in the LVAD patient, and this is what we're going to discuss in trauma patient as well. And you need to think about, are there reversible causes I need to prioritize? Yeah, so is there a priority other than chest compressions and oxygenation? And the other important thing, you need to look at the reversible causes. You need to modify your ALS algorithm if it's needed. Yeah, then you follow your standard ABCDE approach in the peri-arrest situation. Your safety is major priority, especially if talking about toxic agents. And that stage, you should think about early transfer of your patients into hospital to bridge them to some kind of eCPR, and that gets you back to your resources you have out in the field or in the in-hospital setting. So this is the ERC top 10 key messages.
All right, thank you so much for that passionate overview of your top 10 messages. I would have to say AHA did not have the same passion at putting together the top 10. We re-highlighted a lot of the things that we already talked about. So it was just a different take on how we did our top 10. And so we focus on 10 of our recommendations tables, but also the ECLS is kind of a broad overview kind of recommendation, right? So for anaphylaxis, we had a number of well, okay, let me take a step back and just say, we had about 238 total recommendations, right? For us to condense it down to the top 10 was very difficult. And so, there's still a lot more that we can't cover in this 1.5 hour session too, and same with the ERC. I mean, their chapter is equally impressive in scale and scope. So there's a lot to look, but just highlighting some of the more important things that we want people to take away in terms of recommendations, these are it, right? So for anaphylaxis, think about fluids, think about the difference between IM autoinjectors and IV administration of epinephrine in the setting of cardiac arrest, right? We don't want people just to put an autoinjector pen in somebody who has a cardiac arrest thinking that that could be sufficient. It may not be. Also, we highlighted glucagon for beta blocker exposure in the setting of anaphylaxis, and also ECMO there. Cardiac intervention labs, there are a number of things there. I think one big thing I want to highlight here is thinking about intracoronary epinephrine. So that may be something to consider. ECLS across different topics we talked about with potential reversible etiologies. High consequence respiratory pathogens, personal protective equipment is very effective. Hyperkalemia, I don't need to rehash thoroughly. And then next slide, hyperthermia, we kind of already talked about the cooling rate and water immersion. Hypothermia, one key difference here for hypothermia for us is we did not separately carve out, we separately carved out avalanche, and we did not include recommendations for avalanche. This is for environmental hyperthermia outside of avalanche management that ERC does have separate recommendations for. So prolonged exposure, with hyperthermia, you can have prolonged resuscitative efforts with good neurologic outcomes. Also consider ECLS because there are good prognostic scoring systems out there. LVAD we talked about, pregnancy we talked about, just understand for pregnancy that it's just a very complex pathophysiology and lots of things to consider in that patient population, and opioids, again, just rehashing, potentially use of opioid antagonists for cardiac arrest, and also think about take-home opioid antagonists.
Thank you. Before we go, I do want to give you the chance to, we've got one last summary slide to have at the very end, but before we get to that, we've got some time now for some questions. First of all, are there any questions perhaps from the floor of those here? We've had a lot of information over the last... Eric?
This is for our European colleagues. I caught that you said a de-emphasis on Reboa for traumatic cardiac arrest. I'd love to have you elaborate.
I should say, there's one publication where it's in the end, it's two reviews where we based it on, and two reviews that really indicated if you use Reboa in a really non-expert setting, and this is mostly the setting we find if you're in the emergency rooms or on the pre-hospital field, working with that device, then you can cause more harm than you have benefit out of that device. And this is why we de-emphasized it. We have seen too much harm done with Reboas, so in an absolute expert setting in the clinical trial, fine. This is what we state in our recommendations, but not as an overall approach to trauma patients that are exsanguinating.
Anastasia?
So from the audience that are watching us from their homes, so there is also a question regarding traumatic cardiac arrest in the out-of-hospital setting. So if there are only 2 paramedics on scene, do you recommend to start CPR and then treat the reversible causes, or first treat the reversible causes and then start CPR? That's the question.
Yeah, very interesting question, Anastasia, and we have been discussing that question for 4 years. And this is why this time we have a clarification in our algorithm. The algorithm has changed, and the algorithm has changed in a way that we do not want people to cover all the reversible causes. They should only cover the reversible causes that are relevant in the specific trauma patient. But if you have limited resources, and if you have, for example, an exsanguinated patient, it makes no sense to provide chest compressions before there's fluid on board. On the other hand, if you have a resistance process, like a tension pneumothorax, you could chest compressions as much as you want, but you will not pump any blood. And this is what you need to overcome. So I would say this year is look at the reversible causes that are relevant and treat these. And do not do what you started doing following our 21 recommendations, treat all reversible causes before you start chest compressions. No, think about what you do and treat the relevant things.
Any suggestion from American colleagues?
We did not have a traumatic cardiac arrest section, so we are going to stay silent on that.
And probably the next question is addressed to the AHA colleagues mostly. So the question is, are there any difference in naloxone administration guidelines for opioid-naive patients versus known opiate users?
Yeah, that's a great question in terms of dosing. So we did not get that granular in terms of the dosing, specific dosing for naloxone or other opioid antagonists here. The key is to get it, I think the dosing nuances may be related to, the rate of precipitating withdrawal or the need for different doses for different type of opiate overdoses, right? So it was too granular and too many nuances for us to make specific recommendations there.
Thank you for those questions. Back to the team for final comments, really.
Yeah, being conscious on time, we'll just close with the plenary summary from both organizations. From the European Resuscitation Council, the take-home messages are prioritize reversible causes. 4Hs and 4Ts are already well established in our minds, but please add 4Ps for the pregnant patient. CPR remains foundational. So we should offer high-quality CPR, and standard interventions should not delay chest compressions. Special interventions might delay the start of chest compressions, however. Early team activation and system-level coordination are mandatory as they have we have lots of evidence that they improve outcomes. Consider ECPR if feasible in places it is implemented. And final statement, evidence is always evolving, and we wait more and more studies to come out. So for some recommendations that are now based on consensus, we wait stronger data to be sure on what we fully recommend. To HA colleagues?
Yes. So first, I have to make a correction on what I just said. Okay, so we did actually have a dosing table for antidotes that I just remembered. So, we do have some initial broad stroke recommendations for naloxone dosing. So for an adult, our dosing is 0.2 to 2 milligrams IV-IO IM, and then 2 to 4 milligrams intranasal, and repeat every 2 to 3 minutes as needed, and then start 0.1 milligrams per kilogram in kids. And there is a dosing for naloxone infusion as well. But again, like I said, I think it is going to be still very independent depending on the situation. So we didn't get on more nuanced dosing strategy other than kind of what is broadly used. Okay. Okay, so now back to our final summary. So I think, the kind of big take home for us is that we really dramatically increased the scope of what we did here, especially including pediatric recommendation tables in addition to adults. It was a very large document that is very large in scope. And then also, just as I said earlier, the level of evidence remains fairly weak. We do have new algorithms for LVAD and pregnancy. And we recommended ECLS and mechanical circulatory support more broadly, softened recommendation on hyperkalemia, and again, the opiate antagonist is a big consideration for take-home for patients with successful resuscitations. So thank you, everybody, for your attention.
So I'd just like to thank our audience in the room, those online, thank you very much, and thank you very much to the presenters from the American Heart Association, from the ERC, and to my colleague, Dr. Koh.